Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Dr. Jenny Berkovich, board-certified pediatrician and director of education for JOMA. Today's episode is part one of our conversation with Dr. Suzanne Hagler, all about headaches. Dr. Hagler completed her medical degree from the Albert Einstein College of Medicine. She did her residency in pediatrics at Jacobi Medical Center in the Bronx, followed by a residency in pediatric neurology at the Albert Einstein College of Medicine. She then pursued a clinical fellowship in headache medicine at Cincinnati Children's Hospital Medical Center in Ohio. After fellowship, she spent 7 years working at Nicholas Children's Hospital and serving as the director of the pediatric headache program. She now owns and runs her own private practice, South Florida Headache MD in Hollywood, Florida, and continues to be affiliated with Nicholas Children's. Welcome, Dr. Hagler. Hi, Dr. Hagler. Welcome.
Hi, how are you?
I'm good. You are a pediatric neurologist, but you have a very interesting focus and specialty. So we're going to talk a little bit about headaches today, and it's interesting that you focus primarily on that, since like pediatric neurology is so much more broad. So tell me a little bit about kind of like how common headaches even are in the general pediatric population.
Headaches are actually much more common in the pediatric population than I think people generally recognize. Many of the headaches that we see in pediatrics are not that severe or not frequent or severe enough to really be brought to medical attention. And so in general, it's estimated about 60% of children and adolescents have headache to some degree, looking at the last 6 months or so. More significant pronounced headache and particularly migraine, which would be the most common cause of more disabling headache in the pediatric population, occurs in estimated somewhere between 7 to 9% of the pediatric population, more common in adolescents than in the younger kids, but even under the age of 7, we believe about 1 to 3% of kids that age do have recurrent. So it actually is more common than people generally recognize.
So since you mentioned migraine, I want to talk a little bit about like the types of headaches, because I feel like, especially from like a general pediatric standpoint, when patients come in complaining of headache, the fear is that it falls into like one of two categories. One is like something super catastrophic that needs like emergent medical attention, or it's something that they feel is going to be like not catastrophic, but like chronic and debilitating, right? Like potentially a migraine. But the truth is there's so many other types of headaches, right? And names that we give to the causes of them, which is important. The label is important, right? Because the treatment is different. So other than a migraine, right? And other than like really, really bad things like a brain tumor, what are other common causes of headache?
The most common cause of headache in the pediatric population is what we refer to as tension type. So in order to talk about that a little bit more, though, I want to sort of address the general idea of primary headache disorder versus a secondary headache disorder. So typically the way that I think about headaches in anybody, pediatrics, adult ages, is this a primary headache disorder, meaning you have headaches because you have headaches, and it's just something you have, the same way that another person may have asthma, another person may have diabetes, maybe a person who has headaches. And then a secondary headache disorder would be you have headaches because of another problem, right? The scariest type of problem that people think of, brain tumor. But another example of a secondary headache would be a sinus infection or even a cold, viral infection. Headache is part of one of the symptoms of whatever virus you have going on. And lots of other types of, more chronic conditions that or causes that could cause secondary. So we try to put people into one of those two categories when we think about it. Now, what gets, I think, complicated and confusing for people is that for people who have a primary headache disorder, for example, you are a person who has migraine, you are a person who has tension headache, there are things that can trigger those headaches on any given day. So again, if I'm a person who is prone to tension type headache, and I haven't slept well or I'm stressed, I'm going to be more likely to get a headache on that particular day as compared to maybe any other day. That being said, in a primary headache disorder, there are also going to be days where everything seems to be perfect. There is no trigger and the headache comes anyway, right? So we look at it as sort of something that you're generally prone to that may have some outside triggers that make it more likely to happen versus truly something that's happening because of a secondary problem. And then if you took that secondary problem away, the headache would disappear completely.
When you see headaches and try to distinguish primary versus secondary, is it pretty much 50-50 or is it overwhelmingly like a primary issue? And
I think it depends what setting we're talking about. Okay. In the general population, somebody who is having an occasional headache, where it's something that they may mention every so often, not frequently, and it's not that severe and not causing too much of an issue for them, that often is still going to be a primary headache disorder, but more likely to be tension type headache.
And probably less likely to seek care, or certainly like specialty care, right? So I think what you're saying is like that person is much less likely to actually end up in your office, what you're describing.
Correct. Whereas if you look at the patients who are presenting to a neurology office, or even having headaches that are bothersome enough that they're reporting them to the pediatrician, is going to be much more likely to be a primary headache disorder, and also particularly migraine. So the most common cause of headache in the general pediatric population is tension headache, but the most common cause of headache presenting to a doctor is going to be migraine. So it depends a little bit on the severity of the headaches, and I think that what's going to help also tease this apart is to understand what is migraine and what is tension type headache. So maybe we can kind of start with that, and then let's go back.
Yeah, I think that's a good place to start. I feel like especially, and again, just from a general pediatric viewpoint, which is really all I have, is when patients come in with headache. First of all, I have to be totally honest, it's the chief complaint that probably makes me the most uncomfortable because the differential, right? The causes are so wide, and it can absolutely range from you have a cold and that's why you have a headache to this is a looming brain tumor. So I definitely share, like, I think parental anxiety or concern about this, and I always take headaches seriously. But let's talk a little bit about some maybe distinguishing features of attention headaches, since that's the most common one. So maybe I'll feel a little better about seeing these kids in my office, and parents will as well.
For sure. I think that the most helpful way to think about it is actually to kind of work backwards from the definitions of what are these primary headache disorders, what are the things that we look for that are sort of classic for these primary headache disorders, and then also what are red flags, what are things that make you worry that it may be a bad secondary headache disorder, right? So a secondary headache disorder, again, could be something, where maybe it truly is just, they really just don't drink enough water, and they start drinking more water and they really get no more headaches, right? So that's like a benign secondary headache disorder. The ones that you're worried about and that parents are worried about when their kids are complaining more frequently are obviously the bad things, which at the end of the day are extraordinarily uncommon. So less than 1% of what comes into your office as a pediatrician is going to end up being a bad secondary headache disorder. Probably somewhere between 2 to 10% of what comes into the emergency room for headache is going to be a bad secondary headache disorder. A large percentage of what comes into the ER may be more likely to be secondary, meaning a lot of those kids probably have a viral infection or something like that. So it's a secondary headache disorder, but it's not life-threatening or scary. But so at the end of the day, it's really a very, very tiny percentage of kids with recurrent headaches who actually have something bad. But I think it's helpful to work back from definitions. So migraine and tension type headache. Part of the reason that there is confusion even here is because there is a lot of overlap between those two disorders. And I think the name tension type headache is also kind of not a good name. So what is migraine? migraine is, first of all, not just a headache type. Okay. So when we think about migraine, we really think of it as a brain disorder of neuronal hyperexcitability, where your brain is just more sensitive in general. We don't know exactly why that happens. Largely, it probably is genetic. So at least 50 to 60% of patients with migraine, there's a clear genetic component, maybe more. So there's something about the way that the brain is wired. It's more sensitive than the general brain. And that sensitivity for that person, when triggered, will cause a series of symptoms, pain being one of that, because one of the things that gets triggered in that pathway is something called the trigeminal vascular system, which is the pain pathway in the brain. But what also gets triggered is a lot of other sensory disturbances. And so that's what brings along all of the other symptoms that you tend to see with migraine, right? The sensitivity to light, sensitivity to noise, nausea. So sort of this general sensory disturbance. So migraine is not just the headache. Headache is one of the symptoms of migraine, but the disorder is kind of a more broad neuronal disorder.
Are those other sensory disturbances mandatory in order to diagnose somebody with migraine, or can you have either one or just a handful of them to actually meet criteria?
Sure. So that's a really good question, because that's also something that gets commonly confused by people. People think, well, I don't throw up, so I must not have migraine, right? So there is actually, we go by something called the International Classification for Headache Disorders, the ICD-3 version, which goes through specific criteria. But the diagnostic criteria of migraine require, in terms of those associated symptoms, you have to have either photophobia, so sensitivity to light, and phonophobia, or nausea vomiting. So if you have just nausea, but you're not sensitive to light or noise, you can still have migraine. If you are sensitive to light and noise, but you don't have nausea, you can still have migraine. So basically, you need some of those, but you don't need all. And then there are other criteria too that are required for a migraine diagnosis. So you basically also need either moderate to severe pain, a unilateral headache, or sorry, going back. You need either moderate to severe pain, unilateral headache that worsens with activity, or a throbbing sensation is one of the things you report. But you only need 2 out of 4 for a migraine diagnosis. So, for example, you can have a headache that's on both sides of your head. That's actually only moderate in severity, but because you have a throbbing sensation and because it gets worse with activity, that's enough to give you a migraine diagnosis. So the diagnostic criteria are actually, I think, less sort of striking than what people generally think of as a migraine diagnosis. And that's where some of the waters get a little bit muddied between migraine and tension type headache, because there are people who sort of span both of those. I think that happens actually very commonly in kids. So going to what is tension type headache, right? Because that also helps us to understand.
Before we move on to tension, I sort of have it like seared into my brain that migraines have to be episodic, right? You need the on and you need the off. So someone who comes in and tells me I have headaches every day, 4 p.m. after school, happening all the time, and there's no like clear episodes to it, that starts for me to start thinking away from migraine. Is that accurate, or should I still be considering migraine in my differential?
So I would say that that's unfortunately not accurate. So within the migraine definitions, we have what is referred to as episodic migraine, and then what we have is referred to as chronic migraine. The definition of chronic migraine is somebody who is having headaches more than 15 days out of the month, 8 of which are meeting criteria for migraine. So thinking about that means that actually many of their headaches may actually be kind of mild, not have all those symptoms, but 8 out of those 15 are meeting migraine criteria. And that has to have been going on for at least 3 months. That's the definition of chronic migraine. So that person in that category automatically is having headaches at least half the days of. Now, within that population, and we see this more in tertiary headache clinics than you're going to see in a primary practice, but within that chronic migraine population, there are certainly people who have headaches every single day of the month. And there is even a small subpopulation that have headaches every single second. Now, typically people who have that pattern usually don't start out with that pattern from day one. So one of the complicated things that can happen with pain in general, and this is true for headaches, and it's also true for other types of pain disorders, people with back pain, fibromyalgia, all different types of pain, is this idea of something called central sensitization. So there is, for most people, a threshold that needs to be reached in your brain when all of these systems turn on in order for you to experience pain. Somebody who's having pain, headaches, any sort of pain on an every so often basis, typically they have an episode like you're describing, the attack turns on, it's hopefully treated well enough with something that works so that it turns completely off and your brain sort of resets, and then there goes a longer period of time until you have one again. That's sort of a classic episodic migraine pattern. For some people, they undergo what's called chronification, where they go from episodic to chronic. And we think that part of what happens in those people is there's something else going on that kind of triggers their headaches to start to become a little bit more frequent, right? So instead of having headaches once or twice a month, it kind of creeps up to once a week, then twice a week. Sometimes it happens randomly. There are many risk factors that this has been looked at on an epidemiologic basis to sort of identify what are risk factors for that happening. So there are things associated with that. For example, obesity is associated with chronification of migraine. Overuse of acute medication is associated. Poor sleep, asthma actually is a risk factor. Anxiety. So there are many different things that have been associated, but there's not one thing. But we think that what happens is once the headaches start to increase a little bit, and especially if they don't fully go away with an episode. So let's say somebody has a headache, they take ibuprofen, the next day they're feeling better, but not like 100%. But no one really knows what to do with that because they're pretty okay. They go to school,
They
but it's not
function.
fully resolved.
Yeah.
What happens is the more that happens, your brain sort of resets to a more sensitive threshold. So it becomes easier and easier for the next headache to start. And so then you end up in this loop of this very frequent pain. It takes less and less for that headache to be triggered. And then it's kind of just pain all the time. It's like your brain has learned to be in pain. And so we see that pattern as well. And that can certainly happen with migraine. So to answer your question, it definitely can be migraine. If a headache starts off like that every day, right? So like if somebody goes from having no headaches at all, like they tell, and this is something that we look at in the history, right? So if somebody tells me I have a headache every day, one of the things I want to know is, well, did it start off that way? Like, was it sort of this typical pattern of chronification that I just described? Or was it like one day you started with that, you never had headaches before, and then one day you just started with a headache and boom, now you have a headache every day. Or now you have a headache that just has not gone away. Constant, it's there all the time for the last 6 months, some low level of pain, right? So that type of pattern is less likely to be migraine. It happens sometimes. We see that, but that's definitely an instance where you're going to be more likely to be looking for other secondary causes of that.
That does make sense. I find this a little bit validating because the initial approach when someone presents with a headache is to give them a headache diary. And parents hate this, and I can completely understand why. It's super annoying. They're already ill enough, and the child is upset enough to seek medical care. And now all I'm doing them is go home and start filling out a log. So, I really emphasize with how annoying of a request this is, but everything that I'm hearing from you and like making the distinction and really understanding like the root cause of what's happening has to start with the history. And oftentimes just asking these questions in the room, you can get some information, but sometimes they don't know. They're just so used to being in pain that they haven't been looking for triggers or patterns, right? Or anything. And so I have learned that the diaries that they bring back, the headache logs, can give us a ton of information, and can actually help make the distinction. I do want to ask about tension headaches because, right. And again, the label is important. Like, why are we focusing so much on it? Because as we'll probably get to, the treatment is very different. So talk to me about tension headaches.
So, tension. So first of all, the name is, and this is, again, it's words, but like you said, words are important. So the diagnosis is tension type headache. That's what it's called. It's not, we don't call it tension headache. We call it tension type headache. That's the official ICHG diagnosis. The definition of tension type headache, when you look at the diagnostic criteria, are basically like the opposite of the migraine criteria. So it's less likely to be unilateral, more likely to be bilateral, less likely to be throbbing, more likely to be sort of all over in band-like distribution. You are not allowed, officially, you're not allowed to have nausea. But then when you kind of look in the sub definitions, they say people with chronic tension type headaches are allowed to have some nausea. So there's wiggle room within that diagnosis even. And you are allowed to have either light sensitivity or noise sensitivity, but not both. So you can imagine a person who describes a headache that really is blurring the lines when you look at those diagnostic criteria between tension type headache and migraine. Now, why is that? That may be for a number of reasons. One is we do not have a great understanding of what tension type headache is. We have a much better understanding of what migraine is than we did many years ago. There's still a lot about migraine that we don't understand. It is when you look at pathophysiologically what goes on in the brain in migraine, it is extremely complex, and there are a lot of things that we understand and a lot of things that we still do not understand. There has been much less research and attention placed into understanding what goes on in tension type headache, honestly, because generally those patients don't need as much in the way of treatment. And so they don't come to the doctor as often, they don't present as often. And so there's just been less attention paid to it. So we don't have as good of an understanding. There is a lot of debate within the headache world, in terms of two things. One is tension type headache truly a completely distinct disorder from migraine? Or is it really more of a spectrum where some people are presenting more mildly and some people are presenting more severely? So that's one sort of idea that's brought up. We don't really know the answer. The other sort of debate that's gone on is, does tension type headache have the wrong name, right? That name was given many years ago when people were looking at two kind of big categories of headache patients. One where they had these like very sort of significant associated symptoms with their headaches. So they were vomiting, they were seeing spots, shapes, like things that were sort of more, I guess, concrete that made them, I guess, a little bit more believable, I guess, to people for like a true neurologic disorder. And then you have these other patients who have tension type headaches who don't have these associated, very concrete neurologic symptoms. And so they were attributed really to stress, right? So what that first name came out, it's tension type, like the implication is you have it because you're tense. And we know that that's really not true. The same way that migraine, if you have migraine, headaches can be worse in times of stress and can be triggered by stress. Tension type headache is the same, right? So the same way we talked about that if you have a primary headache disorder, there are things that can trigger it, right? Stress, a bad night's sleep, missing breakfast, all of these things can make it more likely for that disorder to turn on. It's not necessarily the root cause, right? If stress was really the only cause of tension type headache, then really tension type headache wouldn't be a primary headache disorder, right? It would be a secondary headache disorder due to stress. And if you just got rid of the stress, it would go away. So I think that when we approach these patients, at least the way that I approach them, is we really kind of have to look at everything, right? We look at the history, the time course, how it started. We try to look for patterns. The question of, journaling and asking them to journal, you can get good information from a log. That being said, I agree with you. It is a lot to ask of people. And sometimes I find that asking them to pay too much attention to their headaches actually kind of makes them worse. So we didn't even get into yet the sort of interplay between psychology and that piece and headache and any sort of chronic pain disorder. But there is a lot that goes into once you have experienced pain, once you have experienced headache, especially on any sort of regular basis, what goes into the anticipation of the next headache, the fear behind, am I going to get a headache in this situation? I don't want to do this because I might get a headache. Am I going to get a headache at school? Is this going to hurt? Is it not going to go away? Am I going to throw up on the bus? All of these things that you start to anticipate when you had these experiences, we know that thinking about it and anticipating about it and worrying about it is one of the things that is likely going to make it worse, right? And so we have to really kind of toe the line between making sure people pay attention enough that they can identify some triggers and patterns if they're there, but also not overly emphasizing this headache as like this massive part of their life that then they become really almost obsessed, and it's nobody's fault, right? The parents want them better, the child wants to feel better, but then you overanalyze to a point where it's actually unhealthy for them and sort of counterproductive. So I think there is sort of a middle ground, and I think the question of do we ask them to do a diary or not probably depends on the patient when they come in terms of sometimes when they come in, they can give a pretty straightforward story and they're already telling you, there are all these little clues that you can look for, and you sort of have a good place to start. And it's not necessarily necessary to start them on. Sometimes they come in and they really cannot give you a good story. And you have, I don't know how often I have headaches. It happens a lot. I'm not sure.
Yeah.
I think so. You get a lot of that. And when you really can't get a clear story, then it can be helpful.
That's helpful. That balance I think is really important. So I'm glad you emphasize it. We talk a lot about like chronic pain, right? And approaches to chronic pain. So I think it's important to have that sensitivity. Let's talk a little bit about treatment. And I find that when we talk about headaches, and especially when we talk about migraines, I think of treatment in two categories. I think of like prevention, right? And what can we do to like avoid having a migraine episode. And then there's the actual treatment. Like what tools do we have to break a migraine? One of the things you mentioned earlier as a potential trigger is the use of acute medication, which I think sometimes surprises people, right? Tylenol and Motrin is our go-to. And I think it still is, but right at a certain point, sometimes it can become detrimental. So let's talk about prevention. What, if anything, can we do to prevent a headache if we know we're prone to them?
Yes. So I guess the good thing is when you think about, does somebody have migraine? Does somebody have tension type headache? Or does somebody have sort of what you would consider to be, let's say, a benign secondary headache, meaning they're really having headache regularly because of some lifestyle piece that's like a really big problem for them, right? The good news is that prevention of all of those headache types in terms of lifestyle is really going to be the same. Right? You're going to be talking about all of the same lifestyle pieces for all of those patients, regardless of which
This is probably such an upsetting thing to hear, by the way, for people, because I think it was like really exciting. Oh, what can we do to prevent headaches? And now we're going to talk about all the things, and it's still like, it's like hard work still, right? It's not like a pill you necessarily take.
Right. So I think, again, that is a line, sort of an important balance to drop. So when you're seeing somebody, and for a parent, let's say, when they're sort of looking at their child and their day-to-day stuff, and when you're seeing somebody as a pediatrician in the office, you collect that data, right? How much fluid are you drinking every day? In this day and age, it's how many Stanleys are you drinking every day? Fine, they answer that question better than how many cups do you drink. Are you drinking any caffeine? Caffeine includes many things that they don't think about. Nowadays, it's Starbucks refreshers. That's like a big one that comes up. People are not aware that those refreshers do have a significant amount of caffeine. What is your sleep schedule like? First of all, how many hours a night are you getting? But then also, how consistent is your sleep schedule? So one of the things that we know is important for headache management in general is consistency. So not changing your sleep schedule super, super significantly between weekends and weekends, for example. So total number of sleep hours, consistency of your schedule, and also quality of sleep, right? Does the child snore? Do they wake up really tired in the morning? Is there anything that makes us worried that maybe they have sleep apnea or restless leg syndrome or something where they're actually sleeping for 8 hours a night, or 10 hours, 12 hours, whatever it is, but not actually getting good restorative sleep? So the sleep piece, exercise. So what's their activity like in general? And then also diet. So are they eating a balanced diet, and are they eating regularly, right? Are they skipping meals? For teens or, some patients, are they avoiding food on purpose, right?
Mm-hmm.
Weight loss, which is a bigger problem nowadays. So kind of diet in general, and then activity level, exercise, and stress. Is there anything major going on stress wise? And are there patterns that you're noticing in relation to stress that are specific to headaches, right? So that being said, you kind of collect that data in a very non-judgmental way, right? The way that then I present the plan to people when we go over things at the end is I may say to them, I think you have migraine, or I think you have tension type headache, or we're not really sure yet. Either way, one of the most important things that we can do to help with any sort of brain problem is really to set up a healthy environment for your brain to heal. Regardless of what you have going on, we know that your brain right now is sensitive to pain. It's having these pain episodes pretty often. And so the better care we take of ourselves, the easier it's going to be for these episodes to get better. Yeah. It's not to say that there's one thing here that's the cause, right? It's not that I think that the only reason that you have headaches is because you don't drink enough. That is an extremely frustrating thing for somebody to hear, right? Or to say to somebody, you have headaches because you're stressed. It's just stress. I can't tell you how many patients have come to me after seeing other neurologists, other people saying, they told me it's just stress. What am I supposed to do about that?
That's not helpful. Right? That's not helpful, right?
Not helpful at all. So, so kind of looking at it from a non-judgmental place, and then saying, there's other things we're going to talk about in terms of your actual headache management and maybe testing that we may do, or maybe medicines that we may do. But one of the things that's going to set the background for a positive environment for which your brain to heal and function well is to take very good care. Brains that are prone to headaches like consistency, they don't like a lot of changes. And so we're going to do the best we can. That being said, I also tell them, we don't want you to be putting your child in a bubble where they can't be a normal kid. We don't want them to be, again, obsessing about some of these things to a degree that they don't feel that they can function as a normal kid. And again, we don't want to be putting any blame on the child or the parent for any of these pieces. And so it's sort of like we set it up and we say, this may help in some ways. I'm not guaranteeing that all of your headaches are going to go away, but it may make it less likely for them to come on any given date. And we're going to start our work on all of this stuff and see what we're left. Right? So like you kind of tease it apart and make those recommendations, not with a promise that if every headache could be cured by just drinking more water, like I would have no job. Many doctors would have no job, right? So it's obviously not that simple. It's a piece of it for some people. I have patients who come to me on day one with perfect lifestyle, right? They're already doing all of those things and they have a headache every single day. So, there's only those things can help in some patients to some degree. And it's important, but it's often not the whole picture.
So what other tools do exist for, let's say we've optimized all the lifestyle things, we're still having headaches. What can we do, or what tools exist in the prevention bucket?
Great question. So we kind of try to put this into a box of like pharmacologic and non-pharmacologic treatments, right? So the non-pharmacologic lifestyle is one piece. other non-pharmacologic or, complementary treatments that are available that, we often tend to be maybe more likely to turn to in the pediatric population where people are more hesitant to use medications for understandable reasons. There are a lot of things that can be done. So kind of going through them. First of all, just touching quickly on comorbidities, we do want to make sure that we're addressing comorbidities. So again, sleep apnea, anemia, thyroid disease. So anything else that can cause headaches, we want to make sure that all of those things are sort of optimized. The psychiatric piece, it's important to screen for potential psychiatric comorbidities. Yeah. We know that anxiety and depression are more common in patients with recurrent headaches, both migraine and tension type headache that is bothersome enough to come to the doctor. So we see that in those patients more so than in the general population. I will say that very often, again, it's not necessarily the cause of headaches. So it may be one piece of it. We don't really know if this is something that just sort of gets inherited together, like maybe those genes are kind of close to each other, or maybe some of the pieces in the brain that are important in migraine pathophysiology are important in anxiety and depression. So one good example of that would be serotonin. Serotonin, there are a lot of targets for serotonin in terms of migraine treatments, and serotonin is one of the things we address very frequently for depression and anxiety, right? So maybe there are sort of overlapping triggers, sort of causes for both in the brain. And sometimes one causes the other. So we screen for them and then we address both things at the same time. Again, I would never say to a patient, the only reason you're having headaches is because you're anxious, go to a psychiatrist. That I think is really one of the worst things we can do because again, we're assigning blame where first of all, that's not necessarily true. Number two, we're kind of implying that it's in your head, crazy, that it's not real. All of those things, that's not going to be helpful for anybody. So I think that addressing sort of some of those patterns and saying we're going to do X, Y, and Z for the headache piece. For some patients, if they do have anxiety that is not addressed, it could be one of the things that makes the headaches worse. So we want to address that piece as well as part of our whole plan, right? It's one of the things that we know can cause chronic medication. It's been associated with that, so on and so forth. The other thing to always remember too is somebody is having recurrent headaches, that can cause significant anxiety and that can cause significant depression. So kind of going back to what I talked about before, the anticipation of another headache happening, how bad you feel because you've missed school or you've missed a social activity or not able to do the things that you want to do. Those things are going to cause anxiety and those are going to cause changes in your mood. We hear a lot of irritability. A lot of irritability is reported. So we need to address that too. And sometimes that is a way to speak to the patient about it too. It's not about, I want you to see a psychologist for therapy because I think that the only reason you have headaches is because you're stressed, but because this is a really hard thing to deal with for anybody. Yeah. And so we want you to talk to somebody who is going to help you cope with this very difficult thing that is going on in your life and also make sure that that stress is not going to be something that makes it even worse, right? So kind of presenting it in that way, but definitely addressing that part I think it's important for a lot of people. And they may be more or less open to doing that. Now, also specific to sort of psychology-based interventions are specific pain-focused treatments. So there's like, I may want you to see a psychologist to help with stress management or anxiety or depression or whatever we see. But then there's also specific treatments. So specifically CBT or cognitive behavioral therapy is what has been shown to have the most evidence. Actually, a lot of good evidence for pediatric migraine and cognitive behavioral therapy. So not specifically going to a therapist so that you can talk about your feelings or your problems, but really to learn specific strategies for how to manage pain when it happens, how to pace properly, how to think about pain when it happens. So specific pain-based treatments. And those are typically not very long, ongoing sort of therapy interventions. That's like go for 6 to 8 weeks, you learn skills, you do the homework, you practice the skills, and then you're kind of done. So it's like it's therapy, but it's doing it from a different way. There are also other psychology-based interventions that can be done. For example, biofeedback can be helpful. Sometimes it will, and sometimes it's part of CBT. and mindfulness-based stress reduction, different things like that. So different things like that can be done. There's also something called PRT, or pain reprocessing therapy, which has become sort of a little bit more up and coming lately, which is another kind of pain focused psychology based intervention. That's kind of like CBT plus almost. That's the way I think about it. And then there are other complementary things like acupuncture, PT, massage. All of these things can be helpful. I think the question for any patient is, what do they want, right? Are they really, really interested in avoiding medication at all costs? Or are they kind of like, don't have time to do those things, don't have the money to do those things, which are very often not covered
Or
by
don't have the patience, right? Because
Exactly.
and each of these things certainly like requires
Definitely.
right time, and like you said, like for CBT, right, there's homework and you have to like learn. So none of these are an easy fix by any
Exactly.
means, right?
None of them are easy. And so again, it's sort of reading the patient and the family and what they have available to them. If somebody's coming to you and saying, I am so overscheduled, I think it's part of the reason I'm having headaches, is I literally don't have a second in my day to do anything extra. And then you're going to come and tell them to go to get a massage once a week
It's
and
not
go to therapy
practical.
once a week.
It's not practical.
It's not practical,
Yeah.
and it's probably not going to help them. If, however, somebody comes to you and says, I really don't want medicine, I love the idea of trying something else, and the child has to be interested, this may depend on the age of the patient, or maybe a teenager who's more interested in this, 6-year-old, for example, right? So it's going to depend a lot on the situation. But if they, sometimes those interventions help. And we don't have a lot of good evidence for telling us, acupuncture really works for headache. Some studies show some benefit over a placebo. Some studies don't really. Patients will tell you, yeah, it helped me, or no, it didn't help me. There's not sort of like a hard and fast, like, yes, acupuncture is amazing for all headache patients. I think that type of intervention is really sort of, dependent on the patient. If there's somebody who enjoys kind of taking a break from their everyday life, going into this office, which may be sort of a calming situation where you have somebody who's paying a lot of attention directly to you, putting their hands on you in a calm-based fashion on a very regular basis, that may be really the reason that it's helpful. And
I think you need to be a spokesperson for acupuncture, because I've never been tempted to do it, but you just made it sound great.
But again, I don't know if it's working because of where they're putting the needles, or just because sometimes people need a break, and that's what works for them. So but that has to be a person who wants that and who responds to that, right? Somebody else is like, that's dumb, I don't have time for that, I don't believe in that. Like, it's not going to work for them. It's not going to work, right? So it's going to depend on the person a lot. Then other non-medication options I will just mention are there are some neuromodulation devices that we're using more and more in Migrate, which probably many people are not even aware exist. And actually, many of them have FDA clearance for the even 12 and up, which most medications actually don't. So there are a few that are on the market. The two that I use most commonly are something called the Nerivio and something called Cephaly. And then there's two others, the STMS and the GammaCore. But these are devices that basically you wear. Either one of them is actually an armband, one is something you wear on your forehead. They use all different types of neuromodulation or neurostimulation. The one that goes on your forehead is sort of like a TENS unit. I don't know if you know what that is, that people use them for back pain. They provide different types of stimulation to the nerves on the outside, with the idea that they are, over time, when you use them regularly, helping to change the pathways on the inside. They actually work for some patients. They're extremely safe. You have to use them. Some of them require twice a day, some of them are once a day, some of them are 20 minutes, some of them are 45 minutes. So it depends on the interest of the patient or whether they're actually going to use it. But those are nice options for people who are having headaches pretty regularly, but maybe not ready for a medication. So those exist, and we use them a lot. There are also some nutraceuticals or vitamins, and those we use very, very frequently. So for me, at least in my practice, if somebody is having recurrent headaches, and then you sort of get into what's the frequency of headaches, right, where it's going to be worth it to start somebody on something that they have to take by mouth every day in order to prevent those headaches, right? So like, where's that line of where that's going to be worth it for somebody? Is it once a month? Is it once a week? So there are sort of loose guidelines for that. Generally, we think about somebody who is having headaches consistently once a week or more, that don't easily respond to acute medication. That's going to be somebody who you're going to think about prevention. I also like to administer disability scores. So I use something called the PEDMITIS in my practice, which is pretty well accepted in the pediatric headache world, where you kind of are asking about how many days a month have you missed in the last 3 months? Have you missed school? Have you left school early? Have you missed a social activity? Have you not been able to do your homework? Questions like that, and you get a score. And then anybody who's ranking more than like mild disability, I will be more likely to want to recommend a preventive therapy. And so, but typically, if we're starting somebody on something that they're going to take every day, I will typically start with supplements first. The supplements that I use most commonly, that I think have the most evidence, are magnesium, riboflavin, which is vitamin B2, and coenzyme Q10. And those actually will work, in my experience, probably about 50 to 60% of the time. So the people respond very well to them, which by the way, if you look at studies of medication and efficacy in migraines, that's about what you get for most medications in studies as well. So
that's very impressive. That's very impressive. One first of all, I love magnesium for just about everything. Like I think every general pediatrician loves magnesium. I feel like it fixes so many things. So I'm like pretty liberal with it. One thing that I think sometimes we hesitate, a reason that practitioners may hesitate recommending vitamins for anything, is because there is not a lot of regulation, right, about like the actual component of the vitamin, and it can vary by brand. Like we always say this, for example, about melatonin, that like really it varies by brand. You don't really know what you're getting. Our coenzyme coenzyme Q10, yes. Magnesium and vitamin B2 pretty well regulated. So if you're recommending like 100 milligrams, right, of one brand, it's kind of equivalent.
It's it's the same issue, right? You run into with anything. There are a few combination supplements on the market that are specifically marketed for migraine, and generally pretty they're not officially regulated. I mean, none of these supplements are regulated by the FDA. So that's the problem, right? So you're looking for a company that at least says that they have some third-party testing, right? There's some outside laboratory looking at what's in them. You can look, like the bottles of supplements will usually say that. They'll have a little mark like EPA tested, or there's a few different symbols that you can look for that show that they've been tested by a third-party lab. So that's one of the things to look for. But there are some combination supplements on the market that are generally pretty well accepted. One of them is called Relief. The other one is called Dolivent. And those have pretty good doses for most patients. You know, one thing when you're treating pediatrics is knowing what doses you like for particular ages, and you know how perfect does that have to be. We don't really know, right? I know what doses were used in the studies, and so I try to kind of get towards those doses, but does it really matter? How much of these supplements are you actually absorbing? A lot of them you eliminate in your urine, so they're not absorbed very well. So the nitty-gritty detail of that dosing matter that much. So, but for some patients, especially if it's going to be easier to take a combo supplement, we'll recommend one of those. If not, I'll recommend that they look for third-party tested brand. The other thing that we run into in pediatrics is that many kids do not swallow pills.
Yeah.
And for the supplements, including the combination ones, the pills are pretty big, and they have kind of a yucky taste and sensation going down. And so these supplements do come in chewable and gummy forms. So then, you know, we have to kind of work with what we have, right? Are any of those brands are you getting exactly what you think you're getting? We probably don't really know. But for the most part, we think they're safe, right? So worst case, you're getting a placebo, which, by the way, in studies has also a very high response rate for pediatric migraine. So all pain disorders,
which is astounding, right? And I think really speaks to the like psychological and psychosocial component of pain, right? Like and just like you were saying, like sometimes just going to the acupuncture place and being there and it's soothing and it's nice and you're getting the attention and the touch, that's the healing piece. That's also, I think, the fact that placebo has such a beautiful response rate, I think speaks to that piece of it.
Exactly. And so I would never tell, a child that I'm giving them a placebo and I hope it works, right? But between, you, me, and the wall, do we know whether these vitamins the reason we use these specific ones is because we know what they do in the brain. And there is some data showing that migraine patients tend to have lower blood levels of some of these supplements. And there are some studies that have some evidence that they might help somewhat, right? But we also know that, again, going back to studies, about 60% of migraine patients will respond, or pediatric migraine patients will respond to placebo. So it kind of, for the first pill you give them, in my opinion, it kind of almost doesn't matter as long as you tell them confidently that it's going to work. That being said, if they don't respond to that first treatment course, I do think that there are, it's not that I think, it's clear, there are patients who will clearly respond to one medicine and not another. So all of the medicines, once we get into the pharmacology category, all the medicines that we use for migraine prevention are doing different things in the brain. They're working on different channels and transmitters. And so we don't know on a brain chemistry level what's going on in one person versus another person, right? So once you get past that initial, like 60% of patients who sort of respond well to some combination of maybe a supplement every day plus good lifestyle and comorbidity management, will get better with that treatment, right? And then if they don't, that's when I start thinking about medication. So, that's when you start.
So let's maybe finish up by talking briefly about options for prescription medication.
Sure. So, all of the medicines, and so we're once we're getting into prescription, we're pretty much talking about migraine at this point, right? For some patient, chronic tension type headache does exist. And so even though the headaches are not that severe, they're having them frequently enough that you start to think about prescription medication. The only medicine that's really sort of accepted as a really preventive for chronic tension type headache would be amitriptyline, which is a tricyclic antidepressant. But besides for that, there is not a whole lot actually out there for prevention of chronic tension type headache. And so we end up basically in a patient who needs medicine, treating it like migraine anyway, honestly, at that point. So talking about all the migraine preventives, all of the medicines up until a few years ago that we use for prevention of migraine are in different categories. So they're all medicines that were originally created to do something else. And then we found out along the way, oh, look at that. It also works for migraine prevention. And so we use them. So the main categories that are used for migraine preventives are, like I mentioned, some of the antidepressants, not SSRIs. So this is, I think, a common misconception. Yeah. So SSRIs really don't help headaches. If truly somebody has anxiety as the cause of their headaches, then if you treat that, then maybe it helps the headaches. But on their own, they really don't. But the tricyclic antidepressants and SNRIs also are helpful for migraine. So SNRIs would be like Cymbalta, which is duloxetine, or Vaccine,
which are commonly used, by the way, for other pain disorders. So it makes sense that headache would be included. And just for clarity, when we talk about SSRIs, we're talking about the typical medications that we use for depression, Prozac, etc.
So things like Prozac, Zoloft, Lexapro. So those really don't work for headaches. They work very, very well for anxiety and depression. Then moving on to the next category, the most common category I think that we use, one of the most would be the seizure medicines, or anti-seizure medicines. So actually the only medicine that is actually FDA approved for the prevention of pediatric migraine is topiramate, which is Topamax. Topiramate is FDA approved for ages 12 and up for the prevention of pediatric migraine. There is no other FDA approved medicine for pediatric migraine. Everything else we do besides for topiramate is off-label. We do it because we don't have a choice. We don't have the FDA approval. We have to do something. And so everything we use is on. So that's just to be aware of, but it is what it is. So topiramate is FDA approved. There are some other seizure medicines that we use for migraine prevention. There's a medicine called zonisamide, which is actually similar to topiramate. Sometimes we use as an alternative. There's a medicine called Depakote or valproic acid, which we use. And sometimes we even go to other less commonly used seizure medicine, Keppra, lamotrigine. Then there are the blood pressure medicines. So beta blockers are used commonly. So most commonly in pediatrics would probably be propranolol. And then we sometimes use calcium channel blockers as well.
And I just want to clarify, this whole list is for prevention. So we haven't even talked about like, I'm having, right, a status, right, an episode that needs to be broken.
Third category of medicine, like I was saying, is the blood pressure medicines. And those are kind of the three main categories. There's one other medicine that is used commonly in pediatric migraine, which is an antihistamine. That one, it's called ciprofloxacin. Ciprofloxacin is a very, very old antihistamine that is really not, antihistamines are generally medicines that are used for allergy treatment. It's not used much for allergy treatment anymore because
it's used for appetite stimulation. So I'm surprised to hear that it's part of the migraine prevention.
So it works really well for migraine prevention. However, it very commonly causes decreased appetite and weight gain. So that's why it tends to be, we tend to really only use it, or I personally use it in the younger kids. Like if we have the younger migraine patients, 4, 5, 6, 7 years old who are thin, some of them not great eaters to begin with, like that's maybe part of the problem. They're very, very active. Eating is not a problem. Overeating is not an issue for them. We will use it, but it is a common side effect of that medicine. It's something we have to watch closely for. And I would almost never, ever give it to a teenager because you don't want to cause a teenager to gain even 1 pound, right? So unless there is a major issue with appetite, which I've seen occasionally, some people with migraines, chronic nausea, they're not eating at all. So for certain situations, it can be helpful, but that's really the only antihistamine that we use for migraine prevention. And it does work really well, but because of the weight gain, we often can't use this. So that's kind of the fourth, non-migraine specific prevention category.
I find that just one other follow-up thought about ciprofloxacin or periactin. I'm thinking about it now and have a vague memory of using it for abdominal migraines, right? Which is obviously a separate entity, but I suspect the mechanism is similar, which is why it works for that type of
yeah. So we didn't even talk about abdominal migraine or all of the other what we call periodic syndromes related to migraine. So there are these kind of migraine precursors, episodic disorders that younger children can get. Abdominal migraine is one of them. So that's basically a migraine, but with pretty much all the symptoms of migraine, except that you have pain in your abdomen instead of in your head. And then there are other disorders too. For example, paroxysmal torticollis, a certain type of episodic vertigo. Colic has been considered to be actually now a periodic syndrome related to migraine. There's something called cyclical vomiting syndrome, which is also sort of a cousin of abdominal migraine, but different. So there are also these other pediatric recurrent episodic disorders, which we think have kind of probably maybe genetic links to migraine or they're a variant of migraine in kids. A lot of those kids who have those disorders, when they get older into adolescence, that piece will go away. And then
they develop migraines.
The majority of them will develop sort of regular, brain migraines later. So a lot for the treatment of them, of those disorders is very similar to what we do for migraines. We use pretty much the same medications. Besides for those older medicines, which has forever been our mainstay treatment, it is important to know that there are now a new class of medicines on the market that are the first medications that have ever been created to be specifically migraine preventers. Those are medicines that block a molecule called CGRP, or calcitonin gene-related peptide. CGRP is an inflammatory neuropeptide in the brain. We think it is very heavily responsible for migraine in many patients. And so these medications have been developed to specifically block just that. That is really nice for a lot of reasons. One is they work really well. They're really very targeted to a piece of the migraine pathway that seems to be very important for a lot of people. So they work. And because they're so targeted, they have almost no side effects. So all of these other medicines that we're using for migraine, again, typically at lower doses than you would use them for if you were treating the problem they were created for, still have a possibility of side effects. We start with the lowest dose that we can. We go up slowly, give people a chance to adjust, kind of keep them at the lowest dose that they need, so on and so forth. And many patients tolerate those medicines very well and they work well for them. But side effects can be an issue for a lot of people. So these newer migraine drugs, we really, in terms of when you take them, see very, very low incidence of any side effects because they're not also sort of accidentally hitting off a bunch of other targets while they do the thing that they're supposed to. People are starting to hear about these medications more and more because they are being advertised. There are celebrities now advertising them. So people come in knowing that these exist. They right now are FDA approved only for ages 18 and up. The medicines in that category. So officially, they're only approved for ages 18 and up. That being said, I use them off-label in patients under 18 as well, as do, many neurologists and headache specialists. Typically, you're going that route when somebody has tried and failed multiple other medications. Number one, because they are off-label. Number two, they're extremely expensive and it's very hard to get insurance to cover them.
That was my next question. As you're describing this amazing new medication, I'm having flashes of that prior authorization paperwork that will surely come my way if I even think about prescribing this. So I was curious how accessible they are.
So correct. So the getting prior authorizations for these medicines is, the bane of our existence. It's, I have somebody who works for me almost full time doing only that. Because it is a huge, huge headache. But we can get them covered when needed, usually. So it's even in adults, they require prior authorizations and the insurance companies want to see that you have tried and failed. Typically what they want to see is that you tried and failed at least 2 preventives from two different categories of those preventive medications. And then they'll consider covering one of these. And in the pediatric population, it's the same, but oftentimes you need to show even more than that because it's also not approved in this age. So those exist and we are using them, and the studies in pediatrics are ongoing right now. So we are starting finally to get a little bit of data from those studies. They've taken a very, very long time to recruit and get done. So we don't have even a paper written yet from any of them, but one of them just released actually a very small amount of data, like a press release, basically saying, so far, it seems to be working in the pediatric population without any major safety issues. So that's with one of them so far, and that was just in July, that press release was. So we don't have any of that full data yet, but hopefully in the next few years we will. So that will be really promising to have more of that availability. Again, those medicines don't work for every single person, of course, but they are a really nice option to have going forward. The other nice thing, interesting thing with those are 3 of them actually, instead of a once-a-day pill, they are an injection that you self-administer once a month. So like a subcutaneous injection that comes with an EpiPen, and it can be administered at home once a month. So that's nice for people to not have to take a pill. So that's important to know about. The other preventive pharmacologic option that I'll mention is Botox. A lot of people are aware that Botox or onabotulinum toxin A injections are used for prevention. Botox is FDA approved for patients 18 and up for the prevention of chronic migraine. So again, going back to what our definitions are, chronic migraine is you have to be having headaches more than 15 days out of the month. So Botox is not something that we're considering. I have patients ask me this often. And if it's not more than 15 days a month, first of all, definitely insurance won't cover it. It's also extremely expensive. And actually the studies looking at this show that it actually doesn't seem to have much benefit for whatever reason if you don't start with headaches more there's a lot of debate around that too. Maybe it doesn't work. But anyway, that's the data that we had. So we do that. Botox is a nice option because, again, in terms of side effect profile, it's very, very good. It's really working locally. And so some of the side effects that we run into with a lot of the other medications, sleepiness, weight gain, weight loss, mood changes, things like that, that we worry about with all these other medications, you don't have to worry about that at all with Botox. However, it is many needles. So, the patients who get Botox injections for prevention of chronic migraine come in once every 12 weeks. So that's once every 3 months. And the protocol for migraine is 31 injections. So it's a lot of injections. It's a tiny amount of liquid that's, injected all over between the forehead, the sides of the head, the back of the head, scalp and shoulders. And it, it only takes about 10 minutes. But you do have to be somebody who is open to injections. So that is an option as well that we use. Again, even though it's not approved for pediatrics, we use that frequently in pediatric, more commonly teen population.
Thank you so much for that thorough response and background. I think this is a great place to stop, and we can pick back up for part 2 on treatment options in pediatric headaches and migraines.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.